Up to 6% of adrenal crises end in fatality, according to a landmark prospective study by Honor and colleagues. A mortality rate of that magnitude demands urgent, precise medical intervention. Yet, patients walking into an emergency room on the verge of one of these crises are frequently met not with urgency, but with profound skepticism. Today, we are analyzing an essay from My Adrenal Life titled Medical Trauma and Adrenal Insufficiency When the System Meant to Help Causes Harm. The piece details how patients with adrenal insufficiency meticulously prepare for medical encounters, communicate their life-threatening diagnosis, and still face severe dismissal, leading to lasting medical trauma. We need to unpack why the healthcare system routinely fails these patients and the psychological toll of that systemic invalidation.
The core conflict here stems from a fundamental mismatch between the nature of adrenal insufficiency and the structure of modern emergency medicine. Adrenal insufficiency means the body cannot produce adequate cortisol, a hormone essential for responding to physiological stressor. In healthy individuals, the brain senses a stressor, such as an infection, an injury, or a surgical procedure, and signals the adrenal glands to pump out cortisol. This hormone manages blood pressure, regulates metabolism, and keeps the cardiovascular system functioning under duress. Patients with primary, secondary, or tertiary adrenal insufficiency lack this automatic response mechanism. They require precise, timely administration of exogenous steroids. If they do not get it, they go into an adrenal crisis, which is a cascading failure of the body's systems. The essay highlights that despite patients bringing clear documentation and emergency injection kits, providers often wait for lab results to confirm the crisis, losing critical time.
That reliance on lab results is the mechanism of the dismissal the article describes. Emergency departments operate on objective, quantifiable data. A patient presents with fatigue, dizziness, nausea, and brain fog. Those symptoms are nonspecific. They overlap with viral illnesses, dehydration, or anxiety. The triage nurse or physician looks at the initial metabolic panel. The labs appear stable at that precise moment. The provider concludes the situation is not an emergency, telling the patient it is probably anxiety or an overreaction. But the essay argues those labs are just a snapshot, and the symptoms often precede clear biochemical changes. This brings us to the technical breakdown of how a crisis unfolds versus how it is measured.
We must look at the pharmacokinetics of cortisol to understand this disparity. Blood tests measure the concentration of cortisol or electrolytes at the exact second the blood was drawn. However, an adrenal crisis is dynamic. A patient might feel the initial cellular starvation of cortisol, manifesting as profound weakness and a sense of impending doom, hours before their serum sodium plummets or their potassium spikes. Furthermore, if a patient took their baseline oral hydrocortisone hours earlier, their serum blood might show normal cortisol levels, but their cellular demand has skyrocketed due to an underlying infection. The labs lie by omission. By the time the metabolic panel reflects the classic signs of a crisis, the patient is already in cardiovascular collapse. This is why endocrinology guidelines stress treating the clinical picture of a crisis immediately, before waiting for lab confirmation. Yet the rigidity of emergency medicine protocols often overrides those specialty guidelines, leaving the patient stranded.
That creates a brutal paradox. The patient knows their body is failing because they have lived with the condition. They communicate the specific medical intervention they need, like an immediate intravenous dose of hydrocortisone. The physician, trained to guard against unnecessary interventions and to trust objective data, perceives the patient as anxious or demanding. The resulting interaction is what the article identifies as medical gaslighting. The provider says the labs are fine, invalidating the patient's lived reality. When this happens repeatedly, the psychological impact is severe. The essay points out that trust erodes. Patients begin to second-guess their own symptoms. they hesitate to seek care, which in the context of a potential adrenal crisis directly increases their risk of mortality.
The historical context of medical authority plays a substantial role in this dynamic. For over a century, the medical model has positioned the physician as the sole arbiter of truth regarding the physical body. Thomas Addison first described the condition in 1855, and for decades it was a terminal diagnosis. Today, patients manage it themselves with synthetic hormones. This shifts a massive burden of medical management onto the patient. They must act as their own endocrinologist on a daily basis, adjusting doses for stress, illness, or physical exertion. They possess a granular, intuitive understanding of their cortisol needs. When they enter the hospital, a space where the traditional hierarchy reasserts the physician's authority, friction is inevitable. The system expects a passive patient, but an adrenal insufficiency patient must be active and assertive to survive. The system misinterprets survival instincts as noncompliance or anxiety.
The essay notes that this dynamic generates a specific type of medical trauma. The patient prepares. They bring their emergency letter. They bring their own injectable medication. They follow all the rules of self-advocacy. The system still fails them. The realization that preparation does not guarantee safety shatters their sense of security. The trauma is not just about the physical danger of the delayed treatment, it is the psychological injury of being rendered invisible and powerless by the very institution tasked with saving lives. The article states that the body remembers. This points to a cruel biological irony for adrenal insufficiency patients. Can we detail that specific physiological toll?
The irony is devastating. Trauma and stress require the body to produce more cortisol. When a patient experiences an invalidating, high-conflict medical encounter, their brain registers it as a major threat. A healthy endocrine system would flood the body with stress hormones to manage the emotional and physical taxation. The adrenal insufficiency patient cannot do this. The medical trauma itself consumes their limited cortisol reserves. They leave the emergency room emotionally drained and physically depleted, pushing them closer to the crisis they came in to prevent. The stress of anticipating the next dismissal, the anxiety before appointments, the hypervigilance, all act as a chronic drain on their system. They are trapped in a loop where the healthcare system induces the physiological stress it is failing to treat.
We should examine the nuances of this systemic failure. It is tempting to view the dismissing providers as malicious. The reality is more complex. Emergency rooms are overwhelmed. Physicians suffer from alert fatigue and deal with a high volume of patients presenting with psychosomatic symptoms or drug-seeking behavior. They rely on heuristics and algorithms to process patients efficiently. Adrenal insufficiency is rare. Many providers may not have seen an active adrenal crisis since medical school. When a patient presents with vague symptoms like nausea and fatigue, the algorithm points toward common benign causes. The system is designed to catch heart attacks, strokes, and trauma. It is not calibrated for the subtle, rapid decompensation of a rare endocrine disorder.
The algorithmic nature of modern medicine is the root cause. If a process cannot be standardized and measured quickly, it is easily ignored. This is a common theme across many chronic and rare diseases, but the stakes are acute with adrenal insufficiency. To use an analogy, living with adrenal insufficiency is like flying an airplane manually while the autopilot is broken. The pilot, representing the patient, must constantly adjust the altitude and speed based on turbulence. The emergency room doctor steps into the cockpit, looks at a single dial that reads altitude stable, and tells the pilot to stop touching the controls. The doctor does not realize the plane is caught in a downdraft and requires immediate thrust. The pilot's panic is justified, but the doctor only sees the momentary stability of the dial.
That analogy illustrates the danger of prioritizing a static measurement over a dynamic trajectory. The My Adrenal Life article suggests patients adapt by creating layers of safety independent of the medical system. They secure clear documentation from their endocrinologists. They carry their own emergency injection kits. They train support networks like family and friends to advocate for them when they are too weak to speak. These adaptations highlight a profound shift in how these patients navigate the world. They operate with the underlying assumption that the medical safety net has holes and they must bring their own parachute.
This self-reliance is a pragmatic response to trauma, but it carries a heavy cognitive burden. The article refers to this as carrying it all alone. The patient is forced to manage the emotional labor of educating their providers while simultaneously experiencing a medical emergency. They must calculate how to present themselves to be taken seriously, assertive enough to get the hydrocortisone, but deferential enough to avoid being labeled as difficult. This performance requires immense energy. The suggested interventions, bringing an advocate or carrying emergency guidelines, are necessary mitigation strategies. However, they do not solve the fundamental issue of systemic invalidation. The true solution requires a paradigm shift in medical training, prioritizing the patient's subjective narrative alongside objective data, especially in rare diseases where the patient is the foremost expert on their own body.
The essay closes on the concept of gentle empowerment, acknowledging that rebuilding trust in the healthcare system takes time. It validates the patient's experience, affirming that the gaslighting and dismissal are real phenomena, not imagined slights. This validation is a crucial step in healing medical trauma. It allows the patient to externalize the failure, recognizing that the system is flawed, rather than internalizing the dismissal as a personal failing or a sign that their symptoms are illegitimate. We have seen how the rigid reliance on lab snapshots creates fatal blind spots, and how the patient's necessary preparation often clashes with the medical hierarchy. If you found this breakdown of medical trauma and systemic blind spots valuable, pass this episode along to someone who appreciates deep dives into the hidden complexities of healthcare.